Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And I'm here to present some of the most important papers from the American Society of Clinical Oncology's annual meeting held in 2025. And the first paper I'm going to talk about discusses Zanubrutinib plus Venetoclax for frontline chronic lymphocytic leukemia, small lymphocytic lymphoma, or CLL, SLL. And the bottom line on this paper is the combination of Zanubrutinib with Venetoclax resulted in nearly a 100% response rate, with 9 out of 10 frontline patients not progressing when they were assessed at 2 years. And this is regardless of their 17p deletion status. This work was led by Dr. Mazyar Shadman of the Fred Hutch and an international group of colleagues who presented the results of one of the cohorts of the Sequoia trial at the American Society of Clinical Oncology's annual meeting in Chicago in 2025. In the way of background, Zanubrutinib is a next-generation Bruton's tyrosine kinase, or BTK, inhibitor that's approved for the treatment of chronic lymphocytic leukemia, small lymphocytic lymphoma, CLL, SLL. The initial results in the Sequoia trial demonstrated superior progression-free survival at 26.2 months in treatment-naive CLL, SLL patients without 17p deletion, and improved progression-free survival at 5 years compared to those who received bendamustine and rituximab. This combination of a B-cell lymphoma 2 or BCL2 inhibitor plus a Bruton tyrosine kinase inhibitor, these combinations have shown great synergy, but there are little data on patients with deletion 17p or TP53 mutations. This abstract presents the results from the Sequoia cohort that was treated with the combination of Zanubrutinib plus Venetoclax in the patients with or without 17p deletion and or TP53 mutation. Let's look at the methods. This was a non-randomized cohort of the Sequoia study of patients 65 years and older or between 18 and 64, but they had to have some other comorbidity. Patients received Zanubrutinib for 3 months, and that was to debulk the disease and reduce the risk of tumor lysis syndrome. And then they were started on standard Venetoclax, which is the only approved BCL2 inhibitor, the standard ramp up in cycle 4, and that was continued for another 2 years, followed by continuous Zanubrutinib monotherapy until there was progressive disease, or the patient could no longer tolerate the therapy, or the patient reached undetectable minimal or measurable residual disease, UMRD, on 2 consecutive tests at least 12 weeks apart. So let's look at the results. First, let's look at the patient population that was studied. This is a group between November 2019 and July 2022. There was 114 patients enrolled, and people remember this was during the height of the COVID pandemic. 66 or 58% of the patients with had deletion 17p or TP53 mutation. 47 or 41% didn't have it, and 1, there was missing data. For all the patients, the median age was 67, a little bit younger than the usual CLL patients. 56% of the patients were male. 75% had the poor prognosis unmutated IGVH, and 41% had complex karyotype greater than 3 abnormalities, also a poor prognostic marker. Let's look at the outcomes. As of September 16, 2024, 75%, 3 out of 4 patients, 85 of the patients remained on treatment. The most common reason that patients had to discontinue were that they reached undetectable measurable residual disease, and that was the reason they had to stop. Some stopped because of adverse events. Some fewer numbers stopped because of progressive disease. 6 patients died, 5 due to non-treatment related adverse events, and 1 due to progressive disease. patients without or with 17p deletion achieved very similar efficacy response. So listen carefully to this part of the study. At 2 years, for the patients without versus the patients with deletion 17p 53 mutations, the results respectively were progression-free survival for those without was 89%, for those with the poor prognostic marker, a better 94%. Overall response rate was 98% for those without the bad marker and 100% for those with the bad marker. And UMRD in the peripheral blood was reached by 60% of those without the bad marker and 59% of those with the bad marker. In other words, almost identical and maybe slightly better results in the poor prognosis group. Adverse events of any grade were, number one, COVID. Over 54% of patients got that. But diarrhea was common, seen in more than 4 out of 10. About a third of the patients had contusions, and about 3 out of 10 had some nausea. The most serious or grade 3 transient adverse events that were treatment-related were low neutrophil counts. Neutrophils are a kind of white blood cell that fights infection. That was seen in 17% of patients. High blood pressure, seen in 10%. Diarrhea, seen in 6%. And other types of low neutrophil counts. So what can we conclude from this? The combination of Venetoclax and Zanubrutinib are proved to be a very effective therapy with no new toxicity signals seen with this combination, and are remarkably high in similar outcomes for those with or without deletion 17p or TP53 mutations. Now, the first combination of BCL2 plus a BTKI to be approved is likely to be the combination of acalabrutinib plus Venetoclax, based on the Amplify trial. But other combinations are showing great promise, including the combination of Zanubrutinib and Venetoclax, and the combination of Zanubrutinib with the experimental BCL2 Sonrotoclax, and both of those combinations are in development. We provide a link to the ASCO abstract, combination of Zanubrutinib and Venetoclax for treatment-naive CLL, SLL, results in Sequoia Arm D. Thanks for listening.